All right, so I got this provocative topic, and you'll find that some of the answers here tend to be a preference, and also some people really feel strongly about this. For me, it's just another tool, because if there is a blood vessel, we can access it. These are my disclosures. Why alternative access? This term alternative access it's not really appropriate, because for the longest time, transradial was considered alternative for years, and then it became the de facto standard actually in the interventional cardiology world. Same thing with transpedal access too. We used to think this was something that you just didn't do, and now it's a routine type of thing, and there are people doing TAMI procedures where they're doing primary access from the foot. So what kind of obvious things are there that prevent you from using usual access? The hostile groin or extreme obesity. The bifurcation perhaps is really too acute. If you have a patient that's got an endograft, or somebody's super tall, it can be a problem. Or the access is stented. We see a lot of this too, where people show up. I just had this last night, and patient's common femoral is completely stented, external all the way down to the pop. So what do you do in those kind of situations? So you need to think about alternative ways of getting to where you need to go. And sometimes you will use pedal primary access. Sometimes you use an R2P radial peripheral access, or radial to pedal, or you'll use a combination. So like I said, I don't necessarily like to think of these things in isolation. These are all just different tools, and just as we talked about in the previous session, you may use multiple anatomies. And the anatomic factors can help you decide, what does the cap morphology look like? How are you going to predict which way you're going to go? In that iliac case that we saw earlier, the cap morphology was favorable for access from both directions, either from a radial approach and or from a transfemoral approach. So, you take a look at that, and that can help decide, in this particular case, you can see in both directions, you could potentially go either from the foot or from above. So what about safety? So obviously, we know that radial is probably one of the safest access points too, and I actually think it's safer than transpedal, even though if you use ultrasound, really that should be a very safe approach as well. Common femorals are not as safe, and there are obviously complications even if you use ultrasound. But it's important to understand these risks, and also think about what happens afterwards as well too. And some of those other alternative techniques, we were talking about perc axillary as well too in the previous session. Those are higher risk access points. Certainly perc ax is probably not as bad as pop or brachial, but it depends on who's doing the case and what kind of issues afterwards. You saw that patient had a pseudoaneurysm in the other case, and that's something you have to watch out for. I've had to treat several of those for these impellas that were placed from a perc ax approach or the TAVR approach as well. So why start this? A lot of the ASC OBL folks actually champion this because of patient satisfaction, early immediate ambulation. Patients aren't laying on their back. They can sit up right away, reduce wait time, increase turnover, less bruising and bleeding. So all these things are very, very important. Initially the staff grumbled about it too, but eventually they started seeing the benefits, not having to deal with a groin that goes south, your sheath falls out, or the patient's closure doesn't take, so now you're sitting there for another 15-20 minutes trying to get hemostasis. Ultimately, these do lead to cost savings, and so this economic story is something that's going to continue to grow over time. And then, of course, there are professional benefits as well, too. If you look globally, the majority of the endo procedures still are transfemoral in nature, and there is an opportunity to potentially do something a little bit different, which may also improve satisfaction overall. So when you start the program itself, too, you typically want to start off simple, maybe perhaps doing diagnostic cases or combination cases. I would not start doing primary R2P right off the bat. I would also be very cautious about iliac cases. Certainly non-calcified cases are possible. You have to have 6 French covered stents. The LifeStream stents do come in that variety with the 7x26, but larger ones, it's problematic. So I would not recommend tackling iliac cases routinely, because we just don't have equipment that can fit through a 6 French form factor. Short segment SFAs and the proximal vessels are fine. BTK, I would tend to stay away from that as much as possible because we just don't have a lot of good equipment to get down that far. And certainly hybrid approaches, though, are possible. So hybrid SFA and also BTK, you can combine R2P with a pedal approach as well. So you can see in this particular case, this is one that you could argue the patient should have had a common femoral endarterectomy, but they refused, and they also had rest pain as well too. This was an issue previously because we didn't have good IVL options, but luckily we do have slightly longer ones now. And I was able to take care of this patient with a transradial turbopower laser catheter with 150 centimeter Ranger DCB. The long shaft Rangers are actually only on the long length DCB balloon, so you can't get a shorty and you have to put a long one in to make it work from an R2P approach. So what about equipment as well too? Ultrasound is key. You definitely have to use extravascular ultrasound, use the smallest needle possible, use aggressive cocktails, so a nitro, verapamil, and you can put heparin in the cocktail if you want to or not. Sometimes that burns the wrist a little bit, so sometimes giving the heparin peripherally is better. Educating the staff about it as well too, to understand where the equipment is. I mean, that's the other thing. When you ask for the long RX balloons, they have to know exactly where they are because oftentimes they're in a separate cart, not in the same areas as the equipment you normally use. And also have a way to close it afterwards. So there's a lot of different things you can use, even your fingers. But ultimately having a TR band or safeguard or whatnot, all of these devices do work. Complications are important. I've encountered a number of these things as well too. Pseudoaneurysms happen oftentimes because somebody's not paying attention. Your TR band falls off, and it can be addressed oftentimes with a little bit of thrombin injection, but some of these patients will require surgery, especially if you go on to develop compartment syndrome. We've had one case of that occurring, a patient that was on chronic anticoagulants and did not get care in time. Vessel occlusion, if it occurs, the patients are symptomatic. Certainly POBA can take care of that, sometimes thrombectomy. AV fistula formation should almost never happen because you use EVIS, and that shouldn't happen. Entrapped sheaths, you have to make sure that the vessel size is at least 2 millimeters or greater. If you go below that, there's a risk of an entrapped sheath. Antispasmodics can help, but remember anesthesia. So if the patients are completely knocked out, you put them under anesthesia, then a lot of times the vessels will relax, and then you're able to pull that out without as much of an issue. Radial nerve palsy has happened to me before too. The patient develops almost carpal tunnel-like symptoms. You can use NSAIDs and whatnot too, sometimes refer to hand as well too. After about 6 to 8 weeks, usually gets better. Sometimes it lasts longer. You have to counsel the patients. Hand ischemia, know what the ulnar circulation is like. Just yesterday I did a case. Radial was too small. I went transulnar to do the case, and it worked great. But you want to make sure that use oxygen saturation on the finger to make sure that their hand isn't going cold while you're doing the case. Equipment is important. This is continuing to be a problem, but the vendors are doing better. We do have a number of companies that make long sheaths now as well too, in various sizes, along with different types of RX balloons as well. These are typically all between 190 to 220 centimeters in shaft length, which is what you need if you want to be able to do at least SFA cases reliably, and even potentially into the proximal tibial vessels as well. And stents are very limited at this point too. We really only have a couple companies that have stent options, but no real DCBs yet that are long length. We don't really have long length IVL. And when it comes to atherectomy, really just CSI thus far. The long length R2P laser is not yet approved, and some of the other technologies are forthcoming but not yet available. We've certainly done some back table modifications. If you have 150 centimeter shaft length, you can certainly get to the common femoral artery. What I would recommend is if you're going to have to do something further distal and the patient is too tall, that's when you're going to do a hybrid approach, potentially come from the foot up in combination with the radial access. And then room setup, this is important as well too. I personally prefer, if I'm, left-sided access, typically you have a shorter distance, it gives you a little extra length. I don't do crossover very much. I just flip the room and I actually just do everything. I put the controls on the other side, put the monitor on the other side, and just move everything over to the left side if I'm going to go left radial. Some people can't do that. They have a tough time with that. In that case, crossover technique can be useful if you want to go left radial. But left radial, like I said, does give you a few extra centimeters of length if you need to address something that with a technology that's not yet an RTP lengths. And then again, when do you avoid it? As I mentioned, if you have severe ulnar disease, small disease, if you're going to need to use specialty stuff that goes beyond the CFA, or if you need large sheets, you're going to typically avoid R2P as your primary access. In my few seconds here, I'm going to show a couple cases here. This is a patient, bilateral disease, focal right SFA disease. IVUS showed severe eccentric calcification. So I was able to take an IVL balloon down because it wasn't the common femoral. Sometimes you even cut the strain relief on the back end, and you're actually able to get a few extra centimeters as well. And the same thing with the DCB as well too. The back table modification, cut off the strain relief, even take off the valve of the R2P sheath, you can get it to go a couple extra centimeters. And then after that, you can see that the patient did pretty well, minimal residual gradient and very minimal disease. Go now to the other side. This is the advantage of R2P. You can do both sides at the same time. Again, same thing here. I did IVL and then also the Ranger drug balloon angioplasty. And then I wired into that subtotally occluded profunda, and then went ahead and ballooned that as well. And then did a drug-coated balloon angioplasty as well. There was some plaque shift, and this is where maybe atherectomy may have been beneficial, but ultimately able to angioplasty the common femoral and end up with a pretty reasonable result as well too on this side. So there was also a little calcified nodule. If we had a long enough IVL, that would have been nice to be able to do that, to treat that with IVL and DCB. But unfortunately, we didn't have that available, so we went ahead and placed a short segment stent there with a very nice result afterwards. Thank you very much.